Good evening, everyone. And it's my pleasure to be speaking here tonight. This is my fourth conference. And I think actually a really exciting time for public health here in the Cayman Islands. As you can see, I'm going to be speaking about putting hearts into health, implementing the PAHO Hearts Initiative here in the Cayman Islands. We are at very early stages of this, but as I think you'll see, there's a lot of good things to come. So to give a bit of information about what the Hearts Initiative is, it aims to improve the prevention and control of cardiovascular disease by tackling hypertension control. So we know that if we can increase the prevalence of hypertension control in the population by 1%, we can then expect to see a nearly 3% decrease in ischemic heart disease mortality and also a 2.4% decrease in stroke mortality. So this can clearly have a very real opportunity to improve health and people's lives, especially here in the Cayman Islands when we know from the 2021 Compendium Statistics that cardiovascular disease is the top cause of disease here in Cayman. So the program's been implemented in 33 countries in the region already, and it's delivered through primary care services. And the way that they set the program up is that it seeks to integrate seamlessly and progressively into the already existing healthcare delivery services. And I really appreciate this aspect of it because it's not looking to kind of take everything away and start from scratch. It's really looking to build on what is already there. It also uses global best practice in the prevention and control of cardiovascular disease. And it improves the performance of the services through better control of high blood pressure and the promotion of secondary prevention. So as you can see, it is an acronym. So HEARTS stands for each of the 6 components that make up the program. So for H, you can see that it's healthy lifestyle counseling. So this looks at different behavioral risk factors, things like diet. The E stands for evidence-based protocols, so we will be looking to have standardized care practices and guidelines across the island. The A looks at access to essential medicines and technology. The R is for risk-based CVD management. The T is about team-based care, so this is looking broader than just the role of the physician. And the S is about systems for monitoring. So what data do we need to have coming in for us to see whether we're able to make improvements in people's care and controlling their hypertension. And as I mentioned, we're at the early stages of looking at this program and getting more information about it and seeing how it could fit for us here in Cayman. And a very important part of that when you're looking to roll out a new program is having a baseline measure. And that's particularly what that final point, the systems and monitoring, feeds into. Because if you are going to be rolling programs out, we need to be able to see how well they're going. We need to be able to monitor them and evaluate them and see where we're making improvements and where we might still have gaps along the way. So what I'm going to spend some time speaking to you tonight is our baseline data. And this comes from the STEP survey that I'm sure many of you will have heard us speaking about before. This is a survey that we conducted in 2023. And this is a household survey that takes a random sample of the population. So we approached 3,300 households, and by using an appropriate sample size calculation, this can give estimates that are nationally representative across the whole population. And those eligible to take part were adults aged 18 to 69 years. And the reason that this is unlike healthcare facility data is that we're not just looking at the individuals who are coming in to receive care. This is capturing everyone in the population. So it gives you insights on those who might not be as routinely in contact with care services. It's called the STEP survey because it has 3 different steps or stages, the first being a questionnaire. The second is then taking some physical measurements. This is things like height, weight, and blood pressure, which is what we're going to focus on today. And the third is then, at a separate occasion, a nurse took a finger prick blood sample, which was tested for blood glucose and cholesterol. And the survey looked at different risk factors for non-communicable diseases, some of which are behavioural, things like tobacco use and diet, and others that are biological, things like being overweight or obese or having raised blood pressure. So the first data that we're going to look at is from the questionnaire. We asked individuals, have you ever been diagnosed with having raised blood pressure? Has this ever been told to you by a healthcare professional? And we found that 1 in 4 individuals in the Cayman Islands, so 25% of the population, said yes. And we also found that this was, unsurprisingly, higher among older individuals. So those in the age group of 45 to 69 years, this was 39%. And among the younger age group, it was lower at 14%. We then asked whether they were taking medication for this, and just over half said they were. So we're already finding some gaps there that we could be meeting of not everyone who's diagnosed is taking medication. Interestingly, 9% also reported that they're taking a herbal or a traditional remedy, and 3% reported that they see a traditional healer for their care. So this was the self-reported data from the questionnaire. We then, as I mentioned, took our own measurements. So from the blood pressure measurements that our team took in the field, we found that a slightly higher prevalence, 30% of the population, had raised blood pressure or were taking medication to treat raised blood pressure. And again, this was higher in the older adults, up at nearly 50% of all 45 to 69-year-olds either had raised blood pressure or were taking medication to treat it. Then considering stage 2 raised blood pressure, so this is when an individual has a systolic reading of greater than or equal to 160 and a diastolic reading of greater than or equal to 100, we found 18% of the population had stage 2 raised blood pressure. And again, this was higher in the older age category at 33%. So what is it that we are doing at the moment to care for these individuals? How are we doing in terms of moving them through the care pathway and getting the care that they need? If we think about the 30% there, so the individuals that we measured to have raised blood pressure or were taking medication, we asked them about their engagement with healthcare services. If we use the numbers from the most recent labour force survey, this 30% would equate to around 20,000 individuals. And that's that first bar on the bar chart. That's that group right there that we're looking to provide care to. And from the questions we asked, we found out that 65% of those individuals were diagnosed. So that's around 13,000 individuals. And we've got a gap there of 35% who are undiagnosed. We then were asking them if they were on treatment, and 50% of that group reported that they were. So this is around 10,000 individuals. So as I'm sure you can calculate, half of them are not on treatment. But also 15% have been diagnosed and are not on treatment. So that's another gap where they've made it through part of the care pathway, but then fallen off at a certain point further along. And then finally, the last bar on the bar chart looks at the proportion who are on treatment, and that this is successfully controlling their hypertension. So this is the group that we really want to be doing well in, and we're currently at 27%, which is around 5,500 individuals. And that shows that we've got 23% of individuals who are receiving treatment, but it's actually not effectively controlling their hypertension. And when we think about implementing the HEARTS program here, they have kind of focused their monitoring and evaluation approach on this last part of the bar graph. So their goal is to get this indicator up to 70%. So we're currently on 23, or 27, sorry, and we'll be working towards 70. As with most healthcare issues, disease burden and access to healthcare is not equal across the population. There are many different factors that it will vary by. There are just 2 demographic factors that we were able to collate in the survey to give a bit more insight here. So one of them was sex. So we've got that care pathway broken down by men and women. So the purple bars are men and the green bars are women. And what you'll note is that the engagement in blood pressure monitoring and management all the way through is higher among women than men. So this is one of the factors that we can think about when we're looking at our programs of how we can address that disparity. And just to give an example, undiagnosis was 44% among men, whereas only 24% among women. And the other variable that we were able to look at and compare this data for was age, so looking at the older and the younger age groups. So again, the same graph structure. In the teal colour, you've got the younger age group of 18 to 44 years. And in the grey bars, you've got the older age group. And we can see that diagnosis and treatment of hypertension is both higher among the older individuals than the younger ones. So to take an example of undiagnosis, this was 56% in the younger age group and 25% in the older age group. One thing just to bear in mind on this slide, though, is that what I said at the beginning, that the overall prevalence of hypertension is greater in the older age groups. When you think about the numbers behind these bars, there'll be more people that are being affected in those grey older age group there. So this might sound like quite a tall ask, going from 27% of hypertension controlled up to 70%, and that we're taking on something quite big, which maybe we are, but it has been really encouraging to see other countries, of those 33 that have implemented this program, have seen some great successes. So one example is Trinidad and Tobago. They implemented the program in 2019, and within 6 months of implementation in 2 of the health centres, they had seen this indicator of hypertension controlled increase from 20% to 36% in one location, and from 30% to 51% in another. So that's pretty rapid improvements in quite a short time. Another example is Chile, so where they implemented the program among a group where they got hearts going, they managed to see the prevalence of hypertension control to increase up to 65%, and individuals where they hadn't got the program rolled out yet, who are on traditional care, the proportion of hypertension control was just at 40%. So I think really what we're wanting to take away from this today is that we don't necessarily have all the details ironed out yet. We're working on that. We're looking at how we can implement this here in Cayman. We've got some really great baseline data to start from so that we know where we're at right now. But our message is that HEARTS is coming. We envisage that this will be a program that we can roll out collaboratively across public and private sector. We will be having a standardized care pathway for hypertension, and we'll be looking into the different options for implementation to ensure that we can best support those that are currently not being met or being missed along that care pathway. So thank you very much for listening. I hope you enjoy the rest of the conference, and I'm going to hand over to Dr. Nick Gent.
Good evening, folks. I see they've taken down that rather old picture of myself that I confess was from about 20 years ago. And the Honourable Wayne Panton recently reminded me that I probably haven't had a haircut since then. Okay. I suppose that the title of this talk should be what I would have done over the past 3 years if I knew then what I now know about the Cayman Islands. Now, a little bit of a disclaimer, first of all. A lot of what I'm about to say may be taken by some as an unfair critique of our healthcare system. But be clear, these aren't bitter words of someone leaving the islands with a grudge, but the words of someone who deeply loves the Cayman Islands and its people. And I think we desperately need the discipline of holding up a mirror to ourselves and when we look at our healthcare systems. That way we can guide our future development better. And please be clear that these are my personal views and thoughts. So turning first to the problems I believe that we face. I pointed out on many, many occasions the extent of extreme and yet hidden poverty, which has been well illustrated as another part of our STEP survey. The second is the inequalities inherent in what I believe is a deeply flawed insurance-based healthcare system that magnifies those inequalities. The third is the wastage associated with an unplanned healthcare system that is largely driven by private provider-led development of care which of course has to be predicated on profitability. These three things place care beyond the reach of many, and care that is based primarily on reacting to disease, not preventing it. In addition, such provider-led development leads to service fragmentation. A patient may be seeing 4 or more doctors, none sharing a common health record, and hence potentially offering suboptimal treatment and sometimes conflicting therapies. If anyone doubts that, you only need to look at the extent of polypharmacy amongst our patients. I regularly see medical records of patients prescribed 8 or more medicines, regardless of critical need, affordability, and the potential for interactions between those medicines. Most worryingly, the sheer number of clinicians practicing in the Cayman Islands is not only creating an unsustainable financial burden on our society, but is a health threat in itself, as the need to be profitable may be tempting over-investigation, reviewing patients too frequently, and planning interventions given too soon. And in some cases, clinicians are providing treatment outside of their scope of practice. Worryingly, in some parts, and I stress only some parts of the healthcare system, I see patients being given unnecessary, prolonged, and frequent care that is building dependency on the clinical services, conflicting with what should be our proper goal, that is the rehabilitation of the patient. Please do not think I am damning all clinicians on these islands. Many, many excellent clinicians practice here who are very dedicated to fighting for the best care possible for their patients. But regulation of clinical care here is, not surprisingly, as we are a small country, a very light touch. The relicensing demands are in today's world minimal, understandably, as access to high-quality continuing education is limited, and we should also be wary that the competitive nature of how healthcare is provided here potentially mitigates against clinicians seeking peer support and team-based care. So against that context, what should I have begun to do 3 years ago, knowing what I know now? I should have looked more closely at the nature of health insurance that tends to prioritise interventional care, not preventative care. But I am reassured to know that there are proposals to change the structure of health insurance contracts that may provide a vehicle for giving greater prominence to preventative care. I'm not a fool. I know there is not a magic money tree, but in an ideal world, there should be no barrier for access to certain elements of care, such as a thoughtful national immunisation programme for all ages, including pregnant women, access to cancer screening for those cancers where there is good evidence that such programmes give net benefit. And despite the enthusiasm of many clinicians for ever more screening, only female breasts, cervix, and colorectal cancers have well-validated evidence for their effectiveness, and even then, only when managed through an efficient call and recall system. I believe that if we could provide maternity services in a way where personal financial resource is not a bar to good clinical protocol-based care, we would be a more just society. And finally, the way that we care for our elderly, our mentally ill, our looked-after children, and our prisoners should reflect our humanity. And our Cinderella services, I think, need more love and attention than we are currently affording them. Significant changes are underway, and I'm sad that I will not be around to see them through. A change of health insurance legislation is planned. Legislation to modernise oversight of healthcare practice is being progressed. The commencement of the Pharmacy Act that will enable a wider range of clinicians to help fill the deficit in chronic illness management and access to affordable care is due. And I thank ministers especially for agreeing to implement the Heart's Hypertension Programme. And I hope that a successful introduction of the hypertension programme will justify the next step, that of implementing the Heart's Diabetes Programme, the two most significant chronic disease threats to our people that we know from steps are massively under-recognised and under-treated. And very dear to my heart is the production of a modern code of practice common to everyone holding a clinical practice license, to include better ethical advice, a common position on issues such as capacity and consent, and the duty of candour. I leave the ministry as good colleagues are working through the logistics and business cases for universal electronic prescribing systems that could bring better management of medicines, prevent the majority of clinical prescribing errors, help to review polypharmacy, and throw light on the prevalence of chronic disease, and amongst others, help to monitor the reach of the HEARTS programmes. Colleagues are also working to develop training for the independent prescribers that will be the clinicians at the heart of the HEARTS programme. We are also close to delivering a rational national healthcare plan and a cancer care plan. These are all good things that should deliver significant benefits over the coming years. But there are many other things that need our attention too. Most prominently are clinicians working to evidence-based care pathways, with more integration in the way that they plan care between themselves. There is no place for individualism or replacing internationally evidence-based care with local ad hoc consensus. The public also has to play its part in reducing its risk to itself. I've spoken previously and extensively about obesity, and I won't repeat my presentation of last year tonight. But regrettably, I see little change or willingness for people to adopt changed personal habits in these islands. And we are condemning many of ourselves to premature death and extended periods of disease and disability before death. Maybe we need to look at social engineering methods to help us. For example, in another area of significant concern to me, the unacceptable death and injury rates on Cayman's roads, which are 4 to 5 times higher than the best performing countries. The prevailing view, it appears to me, is that when a person is caught driving under the influence of alcohol or drugs, they are thought to be unlucky. Not that it is what it is, a just criminal conviction where the privilege of holding a driving licence has been misused to endanger others. I noted a recent Viewpoint article on the Cayman News Service quoted minutes from a meeting of the National Road Safety Committee I had attended, where I'd made a number of points, including the very high rates of deaths on the roads in Cayman due to speeding and driving under the influence of drugs or alcohol, and the failure of doctors to report unfit drivers to DVDL. The comments made by many readers were, to me, surprising, with many blaming the high rates of DUI in particular on the lack of a public transport system. Think quietly on that. That is tantamount to saying, people openly saying, I have a right to go out at night, drink alcohol, and because the state does not provide a system to get me home, I have the right to drive despite being drunk and dangerous. These are just some headline thoughts. I hope you have found them, as I intended them to be, constructive. Finally, on a personal note from me, thank you all for the kindness that you've shown me. I retire finally, for the 3rd time, next week. It's been an honour and privilege to serve as Cayman's Chief Medical Officer. I will look back on my time here with you all as being a highlight of my career and a perfect way to bow out of practice with such happy memories. I leave also confident that you have a strong, experienced and thoroughly able successor in Dr. Wolfe, whose career has already been quite remarkable and whose skills will hold you all in very good stead. Thank you.